So first of all, thank you very much for being here with us today, although virtually. It is the second Journal Club of InnovSpace, of the Space Crew Group, working group. And this session is also in collaboration with the Innovation and eHealth Center of the Carol Dávila University of Medicine and Pharmacy. It's been extremely active in academic and research activities in space medicine, space physiology, and related areas. I don't know, Raluca, if you want to say something right now before we start the presentation of the Journal Club itself. You are muted, Raluca.
No, it's okay. Thank you, Thais. Thank you so much. No, I think it's better to start to engage in discussion because it's a very challenging subject.
Okay. So would you like to pass the floor now or the screen to Lucas Heimberg, Dr. Lucas Heimberg, who's been working with me for a long time in space medicine and space physiology. I don't know how many years, Lucas. One of the, in fact, about a week ago, I think I was like, when was Lucas in Brazil for the first time? And I think that was 2010. Is that correct?
No, 2009. That was my master's.
For God's sake. Okay, so it's a long time that we've been working together. So I pass the word now to Lucas, that he in fact created the idea of the Journal Club, and he's coordinated the second edition. And then he will introduce Tobias, who is going to present the article that we are going to discuss afterwards. But I'll be here all the time, so if you need any help or if you want to make any comment or question, please don't hesitate. We can either use the chat or you can just ask the question virtually. Okay, Lucas?
Oh, thanks, Thais, for that. So yeah, no, welcome everyone. I won't take up too much time because I think Toby's keen to crack on with this presentation. But yeah, so this is the second Journal Club. This is something that I'm hoping to run, 4 or 5 times a year. If there's more interest, I'll do it more. But this is really something I'm happy to lead it and I'll present whenever. But it's really to introduce interesting topics and papers to the space community, to students, doctors who otherwise wouldn't have heard of these papers, to open discussion. And I'm happy for any other students to be part of it. So Toby, he's a medical student from Bristol in the UK. And we've got Christina here, who's also a doctor in the UK as well. He's probably going to present the next one later on this year. But I'm really keen, if anyone else internationally wants to get involved, please do message me, email me. I'm happy to talk all day long like Thais about space medicine. So really keen to get other people involved as well, because it's to help you understand the papers, but then also to open discussion around all these different topics. So yeah, I don't want to take up any more time. So Toby, I'll hand over to you. So Toby's going to talk for half an hour, 40 minutes, then between Toby, myself, and Thais, we'll sort of field discussion, but this is an open discussion. So either feel free to leave your questions till the end or put them in the chat, and then we'll work our way through them at the end when Toby's finished presenting. Otherwise, go for it, Toby. It's all yours.
Right. I don't think I'm allowed to share my screen right now. So Thais, if you wouldn't mind just giving me permission for that, and then I'll get the presentation up. Perfect. Thank you very much.
I feel that's working now. Sorry about that.
No, that's fine. Don't worry. Okay. So in regards to our presentation. So welcome everyone to the Journal Club. We've already done most of the introduction, so I'll get straight to it. Can everyone see the slideshow okay?
No.
No?
Not yet.
I can just still see your screen.
Okay, one sec. Let me swap displays. Is that better?
No.
We'll just see you and the everybody that is attending.
Okay.
So it should.
Let me just mess around with some of the settings for this. 1 second.
You didn't give your computer the right blood group.
Desktop.
Nice, cool. Okay.
It's coming now, yeah.
Is that
Okay.
okay now?
Yeah.
Okay.
Yes.
Okay, so let's get to it. So, welcome to the Innova Space Journal Club. We've done all the introductions. So today we're going to be talking about an article called Blood Transfusion for Deep Space Exploration. This was published in Transfusion, a journal in 2019. Let me just press that. Okay, so this is just a screenshot of the top of the article, basically. I think Lucas has already outlined what we're going to be talking about pretty well, but basically the first half an hour of this will be me critically appraising the article, going through its aims, its methodology, some of the results, and then what are the implications. And then hopefully after that, we'll be able to open up the floor to everyone who can input with reflections or thoughts about things, and we can have some discussion.
Conta aí, doutora.
Okay.
Só um pouquinho, só um pouquinho,
Que atender.
só um pouquinho.
No, go ahead, go ahead. There was,
Okay.
I muted the microphone. I would like, if you could all mute the microphone, you can keep your video on if you want, but just the microphone so there is no interference.
Okay, so firstly, who are the authors? So these authors were from institutions like universities in the States, so the University of Texas, the School of Medicine in Cleveland, Ohio, the Johnson Space Center at NASA, and the US Army Institute of Surgical Research. They declared no conflicts of interest, and they also wanted to sort of emphasize that even though some of them are from the US Army, the views of this article are their own private views. They're not actually the view of that State Department. Okay. And in terms of what I found interesting about this paper, I thought it followed on quite nicely from Lucas's paper because that was about clotting in astronauts. So I thought the next logical step was what about bleeding. It talks about the risk of hemorrhage, whether it's something we need to worry about, and how we would hemostatically resuscitate someone in space. It does this by looking at some of the techniques and methods we'd use on Earth in remote environments when we're not near a hospital. And then it uses those methods to propose its own protocol for what to do in a deep space mission, say to Mars. So why do we have to care? Why is this research question important? Well, because there is a risk of catastrophic blood loss in space. It does exist for astronauts. And as well as that, our physiology does change with exposure to microgravity. For example, with our circulatory system, our heart muscle atrophies, our heart rate drops, our blood pressure drops, our baroreceptor reflex becomes desensitized. And so because of that, it might mean that you could lose a smaller volume of blood and then become more physiologically compromised in space. I don't think we know exactly what could happen yet in terms of blood loss. And in an estimation in the article for a 540-day Mars mission, they found there was a 0.268% risk of EVAC secondary to traumatic hypovolemic shock, which sounds small, but I think when you take into all the possible causes, I think it could be more significant. So obviously trauma can happen in a lot of ways on a space mission during launch or landing or docking, especially with EVA, because you're floating around in space, you're exposed to radiation and micrometeorites and crush injury and so on. And then as well as that, say we did land on Mars, we'd be exposed to gravity again, which means we can fall essentially. On top of that, there's non-traumatic causes like GI bleeding, or you could bleed out during acute radiation sickness. And I just stuck that figure in the bottom right there because that's a picture from Lucas's presentation, which basically showed when they had to fly up anticoagulation for the astronauts during that mission where they found a clot in one of the internal jugular veins of those astronauts. And I think obviously if we start using anticoagulation more in space, then the bleeding risk is going to shoot right up even more. So onto their methodology. So this was a literature review essentially. So the authors did two concurrent searches. So the first one just looked at blood transfusion in remote environments, specifically on the walking blood bank method, but then they also looked at alternative techniques as well. And that turned up 13 articles. One of them was a randomized control trial, 6 of them were retrospective cohort studies, and 5 of them were reviews, and there was 1 case report. These aren't diagrams, by the way, in the article. I tried to make them myself by reading through their methodology. And then the second literature research was just specifically looking at blood transfusion in space. So what are the techniques we could use and what are the potential barriers to this? And this turned up 2 randomized controlled trials, 10 reviews and 2 experimental studies. And this led to the creation of the protocol, which we'll talk about a bit later. So in terms of a closer look at the literature, I mean, I'm not the greatest at evaluating evidence, but only 3 papers were randomized controlled trials, which isn't great. One of them was a large multi-center study, so that was the hemoglobin-based oxygen carriers resuscitation trial. And then the second trial was a French lyophilized plasma trial. I couldn't actually find the third randomized controlled trial in their list of sort of references. And there was no Prisma diagram, so I couldn't see how many articles they'd excluded, what their exclusion criteria was, and it was quite hard to follow their sort of train of thought with their methodology. And yeah, just as a refresher, here's sort of the pyramid of evidence for medical literature and whatnot. At the top, you've got systematic reviews, and at the bottom, you've got sort of just expert opinions. And in general, we're sitting around the middle of this pyramid, so some RCTs, quite a few cohort studies, and some case reports, and so on. So I thought it'd be good, I know a lot of us are from a medical background, to just outline hemostatic resuscitation on Earth first. So obviously on Earth, you donate blood to a lab, and then that blood is broken down or processed into components. So the first main component is red cells. And so a bag of red cells has a 35-day shelf life, and you store it in a refrigerator at 4 degrees. And red cells are great because obviously they're going to carry oxygen to different parts of the body, and they'll give you volume to bring your blood pressure up as well. The second main component are platelets. So a bag of platelets will last for 7 days, and you have to store it at 22 degrees. And I think you can't store it any longer because there's a high chance of bacteria growing inside that sort of medium. And these are your clotting cells. So these are the cells that help form the clot, and you would give them to treat thrombocytopenia, which is a low amount of clotting cells, which obviously you'll be consuming those clotting cells if you're bleeding. Now, the third main component is plasma. And plasma is the liquid component of our blood, so you can break that up further into the specific fractionated plasma proteins, or you could break it into fresh frozen plasma. So this has a 2-year shelf life. You store it at -30 degrees, and it's great if you want to replace your clotting factors, which again, I didn't want to go through the whole coagulation cascade, but they're involved in the coagulation cascade and helping to form that final clot product, and they're great in bleeding. Now, as you've frozen the plasma, you'll need to thaw it again before you use it. And when you do thaw it, you can get cryoprecipitate forming on top, I think. And that is basically just your fibrinogen, which is, fibrinogen is converted to fibrin, which is the final step, if you will, of clot formation. And fibrin forms that mesh that makes up the clot. So on to hemorrhage on Earth. So this is just the standard thing you do in hospital. I got this, I think, from either Bristol Hospital or one of them. This is their major hemorrhage protocol. So if you had identified that a patient was, losing a lot of blood on the ward, you'd call on the local phone 2222, that will go through to the lab. You would activate the major hemorrhage protocol and tell them your location in the hospital. In the meantime, you would give tranexamic acid to the patient, which helps slow down clot degradation. And you would give them fluids as well to bring their blood pressure up. And then the lab would send up a shock pack, which will contain 4 bags of red blood cells and 4 fresh frozen platelet bags. And hopefully that would treat the bleeding. Obviously, you aim to do things like treat the underlying cause as well. But that essentially is what happens on Earth in a hospital. Now, we can't do that in space because there is no lab on the ISS or any spacecraft that is going to have blood ready stored for you that's been donated to you. As well as that, these blood components, as you see, they don't last that long. They're high in mass as well and volume, which means you might have to, that's extra logistical considerations for your spacecraft and how much fuel you need to bring on board. And if it's taking up volume, that's space on board your spacecraft that could be used for something else that might be more important. And as well as that, you'd need to refrigerate a lot of them at low temperatures, which would require a lot of power. So what can we do when we're not in a hospital, when we're in a remote environment? What did the authors find in their results? So the first technique I'd like to talk about is lyophilized blood products. That's quite hard to say. Right now, you can only do it with plasma, and basically it's freeze drying. So you freeze dry the plasma into a powder. And this has been used by the military for 2 decades. I think the French military have done a lot of research into it, and it's quite great because you can store it as a powder at ambient temperatures for 2 years. and it can be prepared for infusion in minutes. You just, I think, rehydrate the powder essentially. And the French military produce a universally compatible product, which basically means it will not, they mix the titers of different blood groups together so that there's not going to be an immune reaction when you infuse it into a patient. And this could be good because in an astronaut's case, you could maybe use it as an autologous blood product. So say in a year's time, you know you're going to space, we take some plasma off you now and store that and freeze dry it. And then on the space mission, if you require plasma, you can prepare that plasma and infuse it back into you. And that's your plasma. So you don't have to worry about infection or any immune reactions. But also, obviously, this is a monotherapy. We can do this with plasma, but we can't do it with red blood cells or platelets yet, because I think the process basically destroys the cells. So yeah. Onto the second technique, so hemoglobin-based oxygen carriers. So this is like a synthetic version of red blood cells. I think a lot of them are solutions of hemoglobin that have been polymerized together. And they were originally developed with the idea to prevent transfusion reactions, because obviously there's no antigens or anything to react with, and to prevent the transmission of disease. They're quite good because they can be stored at room temperature for extended durations. And one of the few randomized control studies in this review did show that there was no statistically significant difference in mortality in shock patients compared to standard care. So that would be IV fluids and then component therapy. So that's pretty good if it's as good as what we use normally. And I think in a space environment, that'd be quite useful. However, there was an increased frequency of adverse events in the synthetic hemoglobin or hemoglobin-based oxygen carrier group. They think this is related to nitric oxide and how these solutions like to scavenge or mop up the nitric oxide in your blood vessels. And nitric oxide helps dilate those vessels. So you're going to get vasoconstriction happening when you infuse these solutions, which could cause something like hypertension and high blood pressure. But if it happens in the vasculature of the heart, that could actually lead to myocardial infarction and ischemic damage. So the third and final technique is whole fresh blood. So as you can imagine, this is literally before blood is separated into its components and processed. It's just all the good stuff. But then with the good stuff comes an increased risk of infectious disease transmission. And also there's a lot of things now in the blood your body could react to and could cause a transfusion reaction. Although so far the evidence hasn't consistently demonstrated this, although in theory we thought that would happen. And the military have looked at this a lot, and they've shown in quite a few retrospective studies that it's at least equivalent, if not superior, to component therapy. So that's pretty impressive. This is a figure from one of those retrospective studies. So what we're looking at here is a Kaplan-Meier curve. So on the y-axis, you have survival. On the x-axis, you have days. So that dashed line there is your whole fresh blood group. And that dotted line is your component therapy or standard care group. And as you can see, after 30 days, the survival was higher in the whole fresh blood group. A bit more about whole fresh blood. So you could essentially call this a body transfusion. You're hooking up one donor directly to the patient, essentially. So you don't have to worry about storing the blood. You would need to screen your donors, of course, and the astronauts would have to be trained how to collect and transfuse blood. And this has been implemented at Antarctic stations. And a big pioneer of this, I think, is Royal Caribbean Cruise Lines. That's why I've got that picture of a cruise ship there. This is a slide from their presentation summing up 7 years of using this protocol. So as you can see, like on a cruise ship, you could have elderly patients on anticoagulants and so on who can fall down the stairs and cause bleeding. So they need to have a protocol for transfusion and hemorrhage. So they've used it on 73 patients. They've had 6 deaths and 4 were lost to follow-up and 2 adverse incidents. But I think that's pretty great because if you imagine, I think the protocol is implemented if you're 4 hours away from shore, so there's no chance of getting the patient to a hospital anytime soon. So these are patients who potentially could have died if they weren't given the intervention. Yep. So after all this evidence and these results, what is the protocol that they actually came up with? So the Royal Caribbean Cruise Lines used the walking blood bank protocol, but obviously in space, because we're different, they came up with the floating blood bank protocol. So the first thing you need to do is you screen your astronauts prior to missions, you check their blood type, check if they have any antibodies to red cells or carry any bloodborne pathogens. Then you need to train them in blood collection and transfusion. And then another consideration they put in was that you coordinate your crew numbers for a deep space mission, for example, by their blood type. So here's some just combinations that they come up with here. If you had a crew of 4 going to Mars, for example, 2 of them could be universal blood donors. Or you could pair the blood groups. So if one A patient requires blood, then the other A crew member could donate to them, or just have all of them as a single blood group. So this is just a bit more about the protocol. So the first thing you do is you just make the decision that this crew member is hemorrhaging heavily, we need to implement the protocol. And then you would identify the donor amongst the crew, and then you'd secure the patient and the donor probably with the crew medical restraint system, as well as securing the equipment to the walls, because obviously you don't want that floating around. You'd measure all their vital signs, you'd put in the IV line essentially, and you'd maybe resuscitate the recipient in the meantime while you prepare all the apparatus and stuff. So they talked about using lyophilized plasma there and using tranexamic acid there. And then you'd use sort of a 3-way low pressure system to withdraw blood from the donor. So I've got a picture of it here, what you could use. So that in between the syringe and the butterfly needle and the bag, that's a 3-way stopcock, which basically means you could have like maybe all 3 valves open at the same time, or 2 tubes open at the same time. So you can just keep withdrawing blood and then turning the stopcock and then pushing it and putting it into that bag, which would have anticoagulant in it. It's important to monitor the donor throughout this so that you're not making them ill as well by withdrawing all this blood from them, and rehydrating them with water as well. And then you would then use a high pressure system to infuse that blood you've withdrawn straight into the patient. And you need to monitor their vital signs and check for a transfusion reaction, obviously, and follow-up care as required and stuff. So that's the protocol basically. So on to the issues with this article, or what, in my opinion, the issues are. So obviously they've developed this protocol from looking at a few different techniques that were sort of evaluated under completely different conditions. Some of them were randomized control trials, some of them were retrospective studies, and so on. And it's not like we've got one big study where we've got all 3 of these techniques comparing against each other. We don't have that, unfortunately, so it's difficult to decide. And like all space research, it's a common theme that they're extrapolating a lot from quite a small evidence base, but unfortunately that's all we can do right now. And I think it's all great and all trying to predict how blood transfusion would happen in microgravity, but there probably will be some challenges or things that make the technique maybe less effective or non-viable that we can't foresee unless it's tried. And then the 4th thing is, I think we're assuming a lot here that, a hemolytic reaction won't happen, or a transfusion related reaction. Even in the UK with a lot of screening and regulation, blood transfusion reactions still happen, and they can be disastrous. They can be as minor as a fever, or if your blood undergoes hemolysis, it's going to tear itself apart and your immune system is going to go crazy. And again, it's difficult to know the effects of blood transfusion on the donor in terms of withdrawing blood from them, and it'd be quite risky if to save one crew member we're actually compromising another one in the meantime. So yeah, that's, in my opinion, the limitations of this article. And my overall interpretation is this is a good start. It's an exciting thought, thinking about how we could treat hemorrhage in space. And right now, given the evidence, this seems the most logical or feasible option. I think with new developments, as someone mentioned at the start, with the development of artificial blood, things are zooming along and things can change. If we discover we can lyophilize red blood cells, that might mean we need to update the protocol, or we find hemoglobin-based oxygen carriers that are safer, that might need to affect the protocol as well. And again, I think everything's in theory right now. It's unlikely to know the effectiveness of this protocol until, well, it happens really in space and we use it and we learn from any mistakes that happen. I don't know how possible it would be to use a space analog to, evaluate this, or maybe look at animal studies in low gravity. Again, it's not, to me, it doesn't seem clear how we could actually effectively prove what the best method is. And just another thing, like I mentioned at the start, we've discovered a venous thromboembolism issue with astronauts and low gravity in space. And if we don't solve that, say we have to make the blanket decision to put everyone on prophylactic anticoagulants, I think this will become a much more important topic, because all of a sudden everyone will be prone to bleeding in space, and we will have to know how to treat hemorrhage more effectively. So yeah, thanks for listening. I hope I didn't talk too fast, but that was the end of my appraisal. So hopefully we can get to some discussion now. We're going to open up the floor. I've just put some example points here if anyone wants to talk about them. But if anyone has any more reflections or anything else, please feel free to input. So yeah, thank you.
Right, great job, Jay. That's really good. Really nice summary of that paper. Like I said, it's a super interesting topic, but has that age-old problem of space-related research of having very little evidence base, and like the CPR stuff that I've done for years, there's just until it happens, it's hard to test it. So all we can do is try and extrapolate data from, Antarctica, military, other remote environments. So yeah, it's a head scratcher. Well, before Toby's obviously put some comments up there. Me and Tice definitely have some comments. But is there anyone else? No one's put any questions in the chat. But if anyone's got any questions, I'll open it to the floor. Directed at Toby, or if you want Tice, myself. If there's any questions, please do speak up. If there are,
Maybe
there are
can you
none.
stop sharing the screen now? I don't know.
Okay, yeah.
I have a quick question, if possible. I was wondering, I don't understand much about submarines, but I think that could be a good analog in this sense, because you have lots of people there and the chance of trauma at least exists, And so do you know the procedures that they use in submarines for store blood or blood transfusion, or if it happens, or if it has happened in the past with accidents or stuff like that?
I mean, I have no idea, actually. I've never heard of that, but I guess it is a consideration. I don't know if anyone else knows.
I don't know the specifics for major hemorrhage protocols and blood products. They do store some blood products, and I've got a friend who he did 6 months on a nuclear submarine as sort of the on-call doctor. So no, they're underwater. These nuclear subs, they tend to stay underwater and don't resurface unless it's life and limb stuff. They can be underwater for 60 days before sort of resurfacing sometimes. So they do implement, so I think combined, they do have some blood products. They can resupply, but they do have a walking blood bank. But they've got a crew of, I can't remember, like 100, 150. So they've got quite a lot of people to choose from. But they do have a fairly healthy young population who can easily be screened before going underneath. So they don't have the same constraints. And statistically, there's always going to be a couple of universal donors who will always be on the sub at any one time. So they do I don't know the specifics of how much they have in terms of blood products, but I do think they do have a good amount. And they use slightly different preservatives. So some of their blood can sort of stay up to 45 to 60 days rather than sort of 35 days. But in terms of incidence and outcomes and how often they've had to use it, I don't have that data off the tip of my tongue. But Taisha, you make a really good point. Particularly nuclear subs, they'd be a very good analog in terms of these guys who are totally isolated and in potentially Tetris sort of high risk environments.
I think that Paul has a consideration or a question.
I would like to thank you very much for the presentation. First of all, it's funny that we don't have universal blood transfusion protocols, universal for all the places on Earth. We are trying to implement one in space, but the issue here is different. You mentioned about the tranexamic acid and all the other things. The problem, though, is not only the blood; it's all the equipment around and all the drugs around. I mean, the tranexamic acid, like any other medication, like the anticoagulants themselves, have a certain shelf life. I don't know if there are ways to make those medications last for such a long period until they will be ready to be given. So we are just opening the box of Pandora, not only for blood and blood protocols and donations and equipment, but also for pharmacology. And I don't know if we still have the answers for this kind of things. I really apologize, but I need to go now. I'm on call, but I'll catch up with the answers later on with the recording.
Thank you,
Thank you,
Paul.
Paul.
Thank you. Bye-bye.
Yeah, I think that's just based on what he said. One aspect that we should also consider is the effect of radiation on these products that are being exposed to a very different environment, not just microgravity, but radiation, and see if they can be somehow affected. I don't know if in the papers that they used there was any consideration about the effects of radiation on the blood products.
No, I
No,
think
it wasn't really
there
mentioned.
was some touching on about sort of the mass power volume concern, which is sort of ubiquitous across all of space flight engineering. Of you got a limited amount of volume. It costs a lot of money and a lot of thrust to get anything up into orbit. So they discussed that a lot. And I suppose leading on from Paul's point that in an ideal world, everything would be freeze dry powdered because you can keep it smaller volume, and it's theoretically less likely to degrade and have sort of be affected by radiation over time. But then to reconstitute all these things takes water. It takes a valuable resource, of which is at the moment a finite supply. Then you're sacrificing one thing for another, because you still need to take enough water to reconstitute all of these things, as well as for drinking, hygiene, and then there's issues again, as Paul said, all the equipment that goes with it. So using one needle, one syringe, a giving set, and then there's issues of fluid mechanics as well in trying to reconstitute something in a vacuum glass bottle like we do on Earth. That's not quite as easy in microgravity to reconstitute something exactly, and then to draw that up and giving it an IV giving set. So there's all these small things, and again, I don't think the review paper touched on it because it's such a Pandora's box of you could go down so many rabbit holes of all these small little pitfalls with sort of giving any sort of drug, let alone sort of blood transfusions. So Paul's done well there to open Pandora's box and walk away.
Yeah. He left the Pandora's box with us
Yeah, very kind of him.
and open.
Yeah.
Okay, so thank you very much, Lucas, Tobias. Any more comments or questions? It's a very interesting topic and it's really not a very common one. So don't be afraid or embarrassed to say something or to ask a question that you feel, oh, it's not a proper question or a comment, but believe me, it is a completely a very open field. It's a very it's not a very well-known field in space medicine. Raluca.
Hi, first of all, I want to congratulate Tobias for his very interesting presentation, and the topic was very generous. From my point of view, there are some elements which could be discussed and could be continued as study research directions. For instance, taking into account that blood volume is completely different in space during space flight versus Earth, and taking in account that generally it's a lower blood volume, this may imply very severe consequences regarding the volume of blood loss, because a smaller blood loss may impact significant hemodynamic balance and blood pressure and especially brain functioning. And continuing in this idea could be several study research directions, for instance, about hemoglobin behavior. does hemoglobin have the same behavior in direction of or affinity for oxygen? There are the same factors which affect oxygen release to tissue during space flight versus Earth. Of course, there are general elements which could be almost the same, but at this moment, I didn't find any topic research in this direction. I know that atmosphere is a little bit or more acclimatized inside, but could be some supplementary factors which may change the behavior of human hemoglobin. And another question, mainly for myself, is about the shape of the cell. Is the same on the Earth, the shape of the red blood cell? Is the same shape, the same property? Does it have the same lifespan duration like on the Earth? There are a lot of questions which probably would be a subject for license paper, master paper, doctoral research, and so on. For me, it's a very interesting idea, and I will try to continue with my small group of but very enthusiastic students to try to answer at least partially in the frame of our limited possibilities to these ideas. Thank you.
Thank you very much, Raluca. I think that that's a very good exercise, is to apply the knowledge that we have here on Earth to whatever we are discussing in relation to space, and also combine with some knowledge that we already have about space physiology and medicine, and try then to apply that to the topic that we are discussing. So you did that very well, Raluca. I think that that's in relation to this, to the amount, or the change in plasma volume that we have in space, in relation to the possibility of the change in the cell shape, and the dissociation curve of the hemoglobin and so on. So it's really open questions. I don't know. I think that nobody knows the answer for that, which for your students and the very nice and pioneering work that the Innovation in Health Center at the Carol W. University of Medicine and Pharmacy is doing. There are topics that could be used for systematic reviews as also or experiments that we could design to try to answer some of these questions, or at least give some light. I don't know, Gianni?
Jenny, was there a question?
Say something about the blood test, and I was wondering about
It is
those
cutting,
changes in-
it is cutting. I can't hear you. Maybe you should turn off your video to try to improve the audio.
It's okay now. Are you hearing me okay?
It's just me or
No, it's cutting in. I'm only hearing sort of every other word. Johnny, yeah, we can't really hear you. Maybe you can always type it in the chat. As long as you can hear us okay, then you should be able to hear our response if you type it in. For some reason we just can't hear you all that well. Sorry.
you are muted, Luke.
I was just asking if Toby knew a little bit more about the hemoglobin-based O2 carriers.
So as far as I know, because I originally thought they were synthetic, but when I read up on them a bit more, I think they actually use like old human sort of expired blood, and then they pull the hemoglobin together and they polymerize it in it. They polymerize the hemoglobin. Yeah, that's as far as I know about it. But I think there's lots of different products. I think some of them are human-based hemoglobin, some of them aren't. Right now, that's why now.
Oh, that's interesting. Yeah. So yeah, in my mind, it's totally synthetic, but it's interesting they sort of pull old blood there.
Sorry, in the final, did you hear my question or not? Because I think my connection was bad.
We can hear you
Now I
now.
can hear you very well.
Okay, I was asking about the artificial red blood cells. Is there any changes in the hemodynamics of the patients that receive the artificial red blood cells or not?
So that's quite interesting, actually. I think originally, Gianni, there was a problem with actually extravasation of the blood. Before they learned to polymerize the hemoglobin, I think the hemoglobin would actually leak out blood cells and it would drag volume with it. So it was actually worsening the patient's state. But since they polymerized the hemoglobin, which basically makes it, I think, less permeable and less likely to leave blood vessels, I think in general it has that, it sort of retains the oncotic pressure within the blood cell and sort of helps bring blood volume up, intravascular volume up.
Okay.
Thank you
I
very much.
could comment on that. The synthetic blood, the blood substitutes are usually more harmful than they are than useful. They cause complications that occur only a few days, perhaps. They may save the life of the person by serving oxygen immediately, but cause complications, a lot of kidney problems later on. Hemoglobin, which is not polymerized, of course, causes other problems that cause iron loading in the blood, which is also toxic. But the polymerized products are not on the market. They're used only in extreme cases where no blood can be served, or a person that has extreme adverse events to blood transfusions, and I think there's only use for veterinary use, not for human use at all. The present point, the whole blood and the walking blood solutions are the leading sources, the leading solutions that are seen mostly in military for sure. And of course, something that I'm working on, and this is why Paul asked me to join this meeting, is we're working on artificially produced natural red blood cells. There's also a group in Bristol, by the way, Tobias, that is doing this.
Right.
You may know them.
I didn't.
So actually, yeah, this may not be a very good alternative for long-term space flight, but for space colonies, of course, because you will be able to manufacture the blood product or red blood cells at the station where the people will be. Maybe not in space, I don't know yet.
Can I ask a question, Ari? How do you produce the red blood cells artificially if they're still in cell form?
Yeah, well, we're using stem cell cultivation technology, and the process uses stem cells that are derived from what we call a universal donor, so that the product cells will be applicable to most humans. Can't say everybody. And the idea is to produce them in a very large scale process, similar to what you see in cultivated meat today, or aspiring to that direction at this point. We're still in the development.
Thank you
Very
very
cool.
much, Ari and Tobias. I just want to point out that in this meeting, you know, as I mentioned before, you have people from many, many different countries here, from Saudi Arabia to Scotland, Israel to Romania, Brazil to Iran, and so on. But one thing that I also would like to point out is that we have at least 3 groups of students here. You know, one that is under Professor Raluca in Romania. One that is under Professor Castro, is also present here. That is Lima Air, which is this League of Aerospace Medicine students at the University in Brazil, PUC-RS Brazil. And we have also, of course, the Space Crew Group of InnovSpace, which is dedicated to motivate this type of activities by creating, motivating the diversity, the inclusion, and also creating networks among students and the other research professors across the globe. So Thomas Dukai is also present here, and he's the organizing this group at InnovSpace. So I'm very glad that we can see that we have 3 groups, very international groups, discussing that, and not just researchers and professors, but also lots of students as part of this activity. So I'm very happy to see that. That's one of my main goals nowadays, is to make very popular space medicine and physiology, as you are heading back to the moon and one day to Mars, and possibly we are going to have space tourism booming very soon. So we need to have more people and more brains working in this area.
Yeah, I think there is a 4th group, which is directly your mentees. So I would be glad to call myself as your mentee in space medicine as well. By the way, my name is Hussein, and thank you, Tobias. That was very, very nice presentation. I really enjoyed it. From aims, goals, even evaluation, everything. That was amazing. My comment would be possibly funny to you, but I wanted to ask, did anybody evaluated how much blood we need in our circulation in space? I think that's a funny but very interesting question. So we need blood for our electron transport chain to carry oxygen to our tissues to metabolize everything. So if we say the primary goal would be this one. So I'm asking, how much blood really we do need in space to do that mission? I think this is the first question, because if we need 4 liter, then if even we lose, I don't know, we have a 1 liter blood loss, that would be okay. We don't need any transfusion. So, or maybe we need 1 liter extra. So we should pump something before the departure of astronauts. I think this could be a funny, but at least I can say we can think about it as well. Thank you everybody again, and this is very nice pleasure to be with you and hear from you. Thank you again.
So thank you for your question. I think, unless I'm wrong and someone can correct me, from the article, they didn't know the targets for transfusion, for the actual protocol, what to aim for in terms of hemodynamically, what you wanted. So I think as of now, I want to say that they're not sure.
Well, I think you're right from the article. But I think the question that Hussein asks is a really interesting one, actually. I think he sells himself short in that you do get a drop in plasma volume, you get a space anemia, so you do get a drop. I can't give you an exact number of how much less blood you have when you're exposed to microgravity. It's not the same as bone density, like you lose 1% for every month you're in space. So I don't think there's an exact number of hemoglobin you lose per month you're in microgravity, but there is a functionality you have to think about, because yes, when you're in microgravity, you've got a flat hydrostatic pressure. There's no more pressure needed from your heart to pump to get blood to your feet than is to your head, as opposed to Earth, you're on one gravity. obviously your heart has to pump against the force of gravity. So in microgravity, you don't have that problem. So you could theoretically lose, half a liter of blood, and you may not actually feel any effect because you're not having to pump against the same, you're not exerting your body, your muscles don't have the same oxygen demands, particularly your lower limbs. So you theoretically could lose a lot of blood in space and not feel the effects. But the concern for a Mars and Moon mission is that you're going to be exposed to hypogravity in 6-9 months' time when you land on Mars. And so that's the goal. You need to somehow maintain the health of your astronauts, not just while they're in transit, not just while they're on the ISS for 6 months, come back to Earth, and then you can rehabilitate them. You need to make sure these astronauts are healthy from day one, and they still need to be almost as healthy as when they land on Mars. Because there's no point getting them to Mars, them to be so unwell that they can't stand up. That's the problem. If they don't have a good autonomic nervous system, they can't maintain their blood pressure, they're so anemic, they can't deliver oxygen to their heart, to their brain, once they're exposed to even a third of gravity compared to Earth or Mars, then they're not functional, and suddenly the mission is at risk because they can't carry out the daily activities, they can't look after themselves, let alone do science. So I think that's a really interesting question, because we probably would tolerate a certain amount of anemia in the ISS because we fly them back down to Earth and we treat them. But for a Mars mission or a Moon mission, we probably wouldn't tolerate that because they need to be independently functional all the way away from Earth on Mars by themselves. They need to be able to have different targets and thresholds. So I think, Hussein, that's a really interesting question. I don't have a good answer. I think, like Paul, opening up Pandora's box and possibly, hopefully, some
There are
research on
studies that show that there is a decrease of between, some say 12%, some say 20% of plasma volume. So this is at least an indication. Let's say that's a mean of 18%, let's say. So this would be at least a reference point for us. But in terms of anemia, it is not, as Lucas was saying, is not very clear the decline, how this decline happen in terms of in the first week, in first month, first 2 months. At least I do not have these numbers in my head. But papers like that or discussions like that, now they just open many doors for us to revise and study, all these aspects that somehow are interrelated. Raluca has a comment or a question?
Yes, first of all, I want to thanks to Dr. Christina Machel. She had a very interesting comment in chat about skipping some shock classes because of the change in the total blood volume, and probably due to this change, it's important to adapt resuscitation or recovery protocols. So probably space physiology, not probably, for sure, should adopt completely different protocols. And finding from Dr. Ari about artificial red blood cells or producing red blood cells, maybe in future we can take in account that the preservation of full blood, not only plasma, could be done by freezing blood, and not at this moment, because everybody knows that blood cannot be frozen at this moment. But I found out about some wood frogs. There are unique animals, unique living beings able to survive at -60 degrees. Their blood can freeze, and then after defreezing, it's in normal shape. And this is due to some change in blood glucose, but there are some additional factors which are not known. And if these factors could be identified and applied to human red blood cells, maybe we can preserve blood in new and other ways, such this breathing. Thank you.
Thank you, Raluca. Any more questions or comments?
I think Christina had an interesting question earlier over practicing retrieving blood for transfusion using three-way valve on parabolic flight. I think in the paper it says they've looked at just getting IV access and they've been successfully able to do that in space flight, but there's some challenges that come along with that, such as restraining patients and supplies and so on with gravity. But as with regards to the three-way system, I don't think there's any mention of them having practice with that.
Yeah, I mean, the problem with studies on parabolic flights, as we know, are just the short kind of bursts of microgravity. So even though it's good and it's a really good simulation, it's quite difficult. And I'm not sure even, you wouldn't be able to actually practice that in like a 40-second burst, I suppose. You might be able to get a cannula in if you're very highly skilled in that time when you're floating around, but obviously you wouldn't have the time to practice the blood drawing. I was just wondering about it because we could have a protocol in place, but as Lucas said, it then comes down, because we've never actually done it, it's hard to know in real life how hard it would actually be just to get the equipment, get the cannula and get the blood out, then give it to someone. And also think about in that situation when someone's bleeding and they need blood, even on Earth, it's like quite a stressful situation to try and instill a major hemorrhage protocol, get a big cannula in, get the blood in as fast as possible when someone's unwell in front of you and needs blood, and add that to floating around in space as well. But I know astronauts need to be calm and cool and collected for that reason. But yeah, no, it's just interesting. I was just wondering.
Yep. I want to clarify my comment. I was saying that as Luki mentioned, I think we need. What I wanted to say is that I'm also suggesting that maybe we need to, I don't know, in artificial labs or whatever, when we can we can make a simulation for hypergravity or microgravity or whatever we can, calculate the amount of blood that we do really need. I think this is the point. I know that there would be some changes physiologically because we're not meant to be in a space. We're not meant to be in Mars. Otherwise, we could do that without any problem. But I'm asking myself, if Hossein wants to go to the Mars in the next 1 year, when facing with hypergravity, how much blood I need to be, I don't know, in my body? How can we calculate it? Maybe we need to do a prophylactic, I don't know, transfusion of blood to our astronauts prior to landing on Mars. So I'm thinking about something like this. Or this is the point. I know there will be some changes physiologically, there would physiologic anemia, whatever. But I'm asking myself, in ISS, what is the constitute of the blood that I really need? What is the volume of the blood that I really need? And then goes to the Mars and then checking it again. This is my question. So if we want to cover a deficit, first we need to prove that there would be a deficiency or there would be a problem. This was my point. So I'm not talking about the physiologic events. I'm asking how can we, predict something and do something prophylactically, not just want to cover something. That was my point. Sorry to interrupt again.
No, thank you very much, Hossein. Yeah, it is all possibilities, all, let's say, hypotheses and theories that somehow it has to be tested. No, maybe nowadays that's so popular. No, maybe an AI system can answer the question to us and say, how much blood we need, or how if there is a need for prophylactic type of transfusion before landing on Mars or stuff like that. The problem, as I think that Christina also pointed out, is even with the parabolic flight that you can have this microgravity, status, the situation, it is so short, and so quick, 20 seconds about. And here on Earth, everything else that we do is so limited in terms of how we can simulate what really happens in space, that all these questions could have been answered by now, but it's so difficult. We really need space flights, and I'm very, in fact, very much in favor of some mathematical models and computer models to try to simulate. I don't know how to do that. I'm a medical doctor. I just ask someone to do it for me. But the idea is that maybe these computational programs could, adding all this information that we already have about space physiology and medicine, with the knowledge that we have here on Earth that is massive, maybe we could create at least this computational model that could tell us something, because it is so difficult to simulate here on Earth anything related to space. I'm very critical about space analogs, although I have been building and working with space analogs for my entire life. Maybe that's why I'm very critical now.
Well, yeah, I think to sort of follow on from your point and sort of Hussein's question is that, yes, I do think there's a ethically good way of answering that question. You've got your 500-600 astronauts who have flown into space or the ISS in all of human spaceflight history. So your sample size is already limited. Not all of those have partaken, and it's difficult to get retrospective data on all those guys. So the only way you could sometimes do animal models. You could bloodlet them. You could remove a certain amount of blood, plasma, hemoglobin, and see at what point they were unable to function in a hypergravity setting. Take them off to space, take out some blood, take them down to the moon, Mars, and see how well they function in the third or the sixth of gravity, and then you could then see how much blood they need back before they're functional again. You could do a very detailed animal experiment on that, and then you could try and extrapolate that to animals. But you couldn't do that, as Christina said, in a parabolic flight. But then physiology in space is not just binary. It's not one system or another system. Again, all of these guys who come back from the ISS, the stuff with orthostatic intolerance, and that's a combination maybe of reduced plasma volume, but it's also a autonomic reset, i.e. your peripheral vasoconstriction is reset, your baroreceptor reflex is reset to a different set point because it's not been used for 6 months. So how can you tease out what is autonomic reflex and what's purely hypovolemia from a reduced blood volume? Even with the best exercise countermeasures we have, astronauts still suffer with orthostatic intolerance despite running on treadmills, lower body negative pressure. Despite these countermeasures, there's no perfect countermeasure to totally remove that confounding factor in that research. So again, super interesting question from yourself, Hussein. I don't have a good answer, but just highlights some of the limitations we have when it comes to space research. And I think AI, again, is pretty good at filling these gaps. We're all aware of ChatGPT, and I imagine AI will probably have a big part in computing our risk going forward. But again, these AI models need a huge amount of data to be able to extrapolate. And yes, we can pull data from Concordia, from Antarctica, from military and other remote locations. But the AI model is only as good as the data you can put into it. And if you've only got 500-600 astronauts, and that's all the data you have, then you're only going to get as good an output from the AI model that you have.
Yeah, no, you are right. And also, I think that you point out something very important, that when you do a study here on Earth, in general, we have one or the most 2 or 3 systems involved. You don't have the full body involved, and that's a huge difference for the space. And I was just thinking about one of the considerations that Raluca made about this, the shape of the red blood cells in microgravity. It might have been done. I'm sorry if I'm saying something completely stupid because it's really not my area. But you could easily see this. This is maybe a question that you can answer quite easily if you use a clinostat and try to create this microgravity environment for the cells, for red blood cells, and analyze their shape in the end of being in exposure to this microgravity simulation for, I don't know how many hours or days, or we could do that for a couple of even weeks, depending on the design of the protocol. So I've been working with clinostats. I developed the one together, of course, with my colleagues in Brazil, especially the Professor Julio from the School of Engineering. So it is quite a kind of easy, let's say, simulator that you can build for cells, and maybe that would answer at least this question. But it's quite complex now to have humans outside our planet. Is a very complex subject, and if they are sick or if they have blood loss, things like that, then it becomes even more complex.
Very much so.
Any more questions or comments, Lucas? I don't know if we are coming to an end.
I think, it's 5:10. I am not aware of the time zones that we have because it's so international. So I don't know if it's very early or very late for lots of people. Raluca, you probably got the best feel of if we're running over or not, if people need to go off somewhere. But I've got no particular questions or points. Thanks everyone for joining in the discussion. I think I'll ask one more time if there's any questions from anyone. Otherwise, my last plea, I think I put it in the chat and Toby has as well. There's a link to a Google Doc form. It's very short, 2 minutes. Like lots of medical trainees in the UK and across the world, feedback for teaching is very important, and it's very good in our portfolios to show that we have done this sort of stuff. So all feedback is appreciated, but it also helps plan for the next one. If there's any particular topics that you guys are particularly interested in, please do sort of put down the feedback as well. So yeah, please complete the feedback sort of before you go, and there should be a certificate from myself and Thais if you fill in that feedback as well.
So the next one will be
So
I don't know when, but it's going to be Christina.
Yeah, so if Christina's there, me and Christina will get our diaries out. We'll look around August, September, it may be later, but yeah, we'll look to do sort of every sort of 3 to 4 months. I said, try and make it 3 or 4 times or 4 or 5 times a year if we can. Yeah, me and Christine will plan a topic and a date, and we'll advertise it soon.
Okay, and I hope we can keep the collaboration with the University in Bucharest and with the University in Brazil, so we can create this network of students and professors from all these places during this type of activity. Of course, everybody else is also more than welcome. So please, when you get the information, the link, the posters, just advertise among colleagues and space enthusiasts, anyone that you believe that will benefit from coming and attending our meetings.
So, Toby, thanks to everyone from around the world for attending. Any last comments, Toby? Your day?
No, just thanks for coming and inputting with the discussion and everything, and enjoy your evening or morning wherever you are.
Thank you, everybody.
Thank you. That was really
have a good
good.
day or night. Take care.
Thank you. Bye-bye.
Thank you.
Great job, Toby. Bye, everyone.
Bye.